Hello everyone, welcome to our Zoom meeting. Today we're gonna have different topics. Dr. Sana and her team will carry on. So whenever you are ready, Dr. Sana, please go ahead. Thank you.
Hello, everyone, and thank you to be here today. Thank you, Dr. Nadir, for this opportunity. We will start the meeting with Dr. Abdelrahman. He will present Delirium. Dr. Abdelrahman. I don't see Dr. Abdelrahman with the participant.
We can start with topic 2 if Alaa
Okay.
ready.
Yeah, weight management using a new method, Ozempic versus Wagovy with Dr. Alaa. Please go ahead, Dr. Alaa, when you are ready. Dr. Alaa.
Hi, Dr. Sana. It's not me, it's a different Alaa.
Okay. Sorry for
Yes,
confusion.
that's okay. No.
Okay. We can check if Dr. Mahasin is here.
Yeah, I'm here.
Can you present your topic now?
Okay, tamam.
Thank you.
Welcome.
Go ahead, please.
Assalamu alaikum, Dr. Nader and the team. How are you?
Alhamdulillah.
Is it my screen appear to everyone?
Yes.
Okay. Good afternoon, everyone. My name is Dr. Mahasin MohamedAhmed. Today I will talking about fire drill and their importance for international medical graduate. So this topic is essential for anyone working in healthcare, especially those who those of us practicing in new hospital system or countries. We will explore what fire drill are and why they are matter for and how IMGs can can play a vital role in ensuring safety during such this situation. So, okay, let's begin. With the basics of fire drill is essential a practice emergency. It's exercise designing to prepare us for a real fire or similar situation. It's teach us how to evacuate safety and respond quickly and coordinate with the other during an emergency. The goal is not only to test our knowledge, but also to train us so that when an actual emergency occur, can we respond calmly and effectively? Okay, fire drill are not just a hospital formulate; they are mandatory safety measure and the part of our professional duty. Okay, hospital are a complex, high-risk environment. Fire in a healthcare uh, healthcare setting can spread quickly because of presence of oxygen tank, electrical, and various materials. On the top of that, many of our patients are unable to move on their own. Think of ICU patients, those on a ventilator, and in operations theater. A hospital cannot simply shut down during an emergency. So preparedness is crucial. Even a small fire can disrupt critical care service and can put life at the risk, both patient and the staff. So fire drill service, it's very important. First, they test how well our hospital responds under pressure. Second, they help familiarize staff with the evacuated routes and alarm. And third, they reinforce individual responsibility and the teamwork. During drills, weaknesses are identified. Maybe an alarm is not loud enough or exit is locked. And then improvement are made before real emergency happen. The ultimate objective is simple: protect life and property through preparation. Okay, now let's look at what typically happens during a hospital fire drill. It usually starts with alarm activation or either planned drill or surprise one. Okay, staff then responds using race protocol. Okay, R for rescue anyone in immediate danger. A for active the alarm and notify others. C for contain the fire by closing door. E for evacuate if it's safe to do so. So patients are evacuated to safe areas. Sorry, roll calls are done at assembly points, and and then session follow to discuss what went well and what need improvement. Okay, what's important for IMGs now? Why is this especially important for IMGs? Many of us come from different healthcare system where fire code, alarm, and emergency procedure look very different. Okay. In a new hospital, even simple things like sound of fire alarm, the location of exit, or the meaning of term like code red might be unfamiliar. By actively participant in drill, IMGs not only ensure their own safety, but also demonstrate professionalism, adaptability, and teamwork. It's part of our responsibility as a licensed healthcare provider to prepare and protect our patient. Okay, every person in a hospital has defined rule during a fire drill. Okay, all staff must stay calm, follow the race protocol, and can help guide patient. Nurse usually assist immobile patient and uh, uh, and secure medical record. Doctors include IMGs often take leadership role in a patient evacuation and coordination. Fire marshals or safety officers direct the overall evacuation and communicate with the fire team. The last thing, security staff help manage assembly points and restrict access to the danger zone. Knowing your role in advance ensures smooth coordination and prevent chaos. Okay, okay. Our training as IMGs may be face certain certain challenges during the drill. For example, unfamiliar terminology. Some hospital code red or use specific alarm tone or UB and U a new to building layout and not know the nearest evacuation route. Okay, cultural difference can also play a role. In some countries, drill may be not emphasized as much. To overcome these barriers, always attend hospital orientation sessions. Take time to locate fire exit and assembly point in each area. Also, ask a supervisor for clarifications during drill. Remember, asking questions now can save lives later. Okay, fire drill are not optional. They are legal and ethical obligations. Regularities body like Joint Commissions and OSHA require healthcare institution to conduct they regularly. Hospital can even lose their accreditation if they fail to comply. Ethically, our primary duty as the healthcare professionals is to ensure patient safety in every circumstance, not just medical care. So, participating in a fire drill is not just compliance; it's an expression of our ethical commitment to safety. So this is best practice for IMGs. Okay, learn to apply RACE and PASS principle. PASS stand for pull, aim, squeeze, sweep. The prop may be to use a fire. So get familiar with the fire exit and the fire. An alarm. Okay, stay calm. Stay calm. Patient will mirror your behavior during emergency. Communicate clearly and follow your leader team. Okay. Last thing. After every drill, participate in the feedback session. Your observation may be help improve the next one. These small steps can make a big difference in the real life safety situation. So here we have a case scenario. Let's look at the short case scenario. Imagine you are on night shift and hear a code red in the neighborhood ward. As an IMGs, what should do? First, pause ongoing taxes safety and follow RACE. Rescue, alarm, contain, and evacuate. Help move patients if required. Reassure those are anxious and maintain communication with the safety team. After situation or drill, always attend to the next sessions that where learning happen. It's also a good moment to reflect on your own confidence and the understanding of the hospital safety system. So, in conclusion, to summarize, fire drill are more than routine exercise. They are essential to keeping those patient and staff safe, especially in the complex environment like a hospital. For IMGs, participating in these drills help with adaptation, confidence, and professionalism. It ensures that in emergency, you are not just bystander, you are an active, prepared member of the team. Always remember, preparedness today prevent panic tomorrow. So thank you, guys.
Thank you so much, Dr. Mahasin. I think
That's
this is
Dr. Nader.
a very important topic, and we need to know how to react, and you will be responsible. And as a leader, you need to know these steps, like what exactly you need to follow. And as Dr. Mahasin mentioned, there are certain protocols or steps that might be very helpful during emergency. I'm gonna share with you in the chat. This is an app that we developed. I think we talked about it if you were with us in the past. But basically, this is a website where you look at what the 3 steps you want to do. Basically, the rest, the pass, how you do the sweeping and so on. If you have a minute, maybe you can look at these videos and be prepared. But thank you so much, Dr. Mahasin. Any questions or any comments?
I have a question.
Go ahead.
Okay, so like this is actually like a really good topic, but I feel like this would rather come off as ignorant from my side because how do you, let's say like a hospital, like there's a fire, right? How do we transfer like disabled like or like, you know, people who are unable to walk, let's say people in the ICU, or like how is that realistically done?
Good
Thank you.
question. And this is actually happening in real life, like last month in, I think, Tennessee or somewhere in one of the states south. They had a fire in a building that was a nursing home. So one patient died, one staff member died. So basically what they do, if there is a fire, they have a protocol of taking all the patients from that floor to other floors, whatever means they can use. In all fires, you are not supposed to use elevators. So most likely, they will take them from the place where the fire is, move them if they are not able to walk, take them with wheelchairs, or take their hospital bed, the patient if he's lying in bed, and move that bed to a safety place. Most of the time, the units will have doors. So on the same floor, they will have right or left, north, south units, and in between there are some doors. So if the fire started on one part of the floor, they take these patients from this side to the other side and lock these doors so they contain the fire in that place until the fire department come and take care of the fire. But the patients, there is a way of moving them from one place to another safe place, if that answers your question. Thank
Yes,
you.
thank you so much.
Yeah.
Thank you so
But
much, Dr.
at
Mahasin.
least you need to know how to use the fire hydrant. So in each floor, there is at least one or more of this fire device. So the first step is it has a pin. You take that pin out, it will be active, and then you will aim, and then start shooting the material that comes out, and then sweep from right to left, from up down, the fire, if you can handle it, if it's a small one. If it's a big one, you need to call and you need to close the door. Your safety and the safety of other people around you, the patients, the staff, is important than controlling it if it's out of control. And make sure there is a way of you to get out. So you don't go in a room and you put yourself in a situation where the fire between you and the door or the exit, if that makes sense. Thank you.
Yeah, thank you.
Thank you, Dr. Nadir, and thank you, Dr. Mahasin, for the informative topic. Now we will start with Dr. Malaz. Are you ready, Dr. Malaz? Dr. Malaz? She was right now on the
She is in the
WhatsApp
list.
with
Maybe
me.
she is. Dr. Malaz, if you are muted, please unmute. Or there is Dr. Alaa or Dr. Abdelrahman, if anyone.
I tried to contact Dr. Alaa, but she didn't answer my call, and I don't have any contact to Dr. Abdelrahman. Dr. Abdelrahman, are you here?
Oh, sorry. So I'm gonna talk about the topic delirium. Let me just start with this question. What do you know about delirium? Anyone can help me identify or define what do we mean by delirium? Anyone can jump
Yeah,
and
Yes, delirium is a acute onset of a disturbance, the level of consciousness or a loss of consciousness for a while for many reasons. And most of these reasons are the acute conditions such as infections, alcohol intoxications. It's acute onset, so we have to deal with it as an emergency and acute situation.
excellent. That's good. And so we have different reasons for the delirium to happen, and it can affect people who are uh, at risk. Can you name some of the individuals that are at risk for delirium?
I can jump for this question.
Yes.
Patient with infection, for example, UTI, pneumonia, or patient with electrolyte imbalance or dehydrations. Also, the geriatric patient with severe illness or organ failure. They can have delirium. Sometimes some medication can cause delirium also. And patient on ICU, I think they are also predisposed to delirium. Um, uh, alcohol or alcoholic patient or drug intoxication also.
Yes. So any group that's like geriatric population or even younger population, if they exposed to, as you mentioned, alcohol, drugs, medications, or changing conditions, electrolytes, anemia, infections, and others, you are right. Thank you, both of you. So I'm gonna try to find the file.
We can add to that
Dr. Nader, you
the
are
organ
muted.
failure, like liver failure, kidney failure.
Dr. Nader, you are
Yes.
muted. Mhm.
All right. Thank you so much. Yeah. So yeah, any functional decline in of any of the major systems like renal function, liver function, anything goes on is the brain. Yeah, you're right.
Yeah, like encephalopathy, uremic encephalopathy, or liver encephalopathy, hepatic encephalopathy, I mean. Yeah.
That's true. Yes.
Okay, thank you.
Excellent. Thank you. So these are slides made by the American Geriatric Society, and they mainly teaching slides for fellows who are doing geriatric fellowship. So the objectives as listed here, we need to recognize it and how to address it, and in certain situations, how to prevent it. It's more common in older patients. So at the hospital, when the patient is admitted or seen in the ER, and then they try to get them into floors, they need to assess the patient for the risk of delirium so that they can prevent it from happening. It's common, and it has effects on the patient and on the general system. Like there are certain factors that contribute to delirium, but the name itself, delirium, can be used in conjunction or in different ways. One of them is acute confusional state or acute mental status change, or altered mental status, or as in this case, toxic or metabolic encephalopathy. So there are different terms that can be used, but the condition is the same. So what exactly is happening, or the definition according to the DSM-5, it's a disorder of attention and awareness, develop acutely and tense. The keyword is to fluctuate up and down. So the person might be with it 1 minute, and you come 15 minutes later, the patient will be confused. An hour later, the patient may become attentive and able to answer. 2 hours later, the patient may be confused again. So it fluctuates in two areas, the attention and the awareness, if that makes sense. And it's very common, as one of you mentioned, in the ICU, inpatient hospital, older patients, they are very high risk for it. At the end of life, also, it's very common. Certain conditions can put the patient at risk. So it can have acute effect and it can go away, or it can have a lasting effect, which is like a poor long-term effect. Sometimes the delirium, because of an infection, when you treat the infection, the delirium will go away, and it depends on how many other conditions contributing to that delirium. It may take a few days, it may take a few weeks or months. So the best option is to prevent it, but if it happens, you want to treat it, addressing all possible causes to fix it so that it can go away sooner. There are some tools that we can use. One of them is confusion assessment method, or CAP. This is developed in one of the hospital, and mostly in the ICU, but they can use it in regular floor and so on. So what that entail, it's basically you want to assess acute change in mental status or fluctuation. The component beside that is inattention and disorganized thinking. So the thinking might not be with it all the time. It may vary. And then the altered level of consciousness. They may be sleepy at one point, and then another point they may be awake, fully awake. So at least you want to have one and two, and either three or four, so that you can identify a patient with delirium. So acute change in their mental status or fluctuation during the course. And the keyword also is inattention. In addition to that, you're thinking about disorganized thinking or altered status or altered level of consciousness. Here, so the diagnosis, you can use these tools like CAM ICU for patients in the ICU. And there are a couple of other variation. So for non-patient, non-verbal patient, you want to use some of the other tools as listed. So there are BCAM and so on. Basically, it's the same concept, but you use it in a different population, different group of patients. How you do it, there are methods. So there is a form, and then in the form there are some instructions as far as what to look for, and you score. And you do this mostly when you see the patient on admission, or you do it if there are some changes in the patient condition. And some of them are very good. So these are also different version of the CAM. But the Delirium itself, it can be a spectrum. So the patient may be drowsy, sleepy, awake, and come back sleepy, or they may be agitated and hyperactive and suspicious and like doing certain things. So we call it hyperactive, agitated, mixed group, where it's composed 25%, and most of the time hypoactive delirium, where they are kind of relaxed, but they just confused. So excuse me. As mentioned, the CAM itself can be used for short or long-term forms, and you can use it. Different hospital may have different forms for you guys when you start your rotation in family medicine, internal medicine, or other neurology, psychiatry. So at that moment, you will understand what the forms are used for what population of patients and so on. How to explain what's happening? So here, the neuropathology. So there are changes that are happening and imbalance kind of situation. Basically, it caused by many factors as listed or has mentioned by the fellows here. But basically, your body is in equilibrium, and if anything make this balance go away, whether it's medications, alcohol, infection, hypoxemia, anything that make these changes, then you will end up in a delirium condition. That. So here's another way of doing it, like getting inflammation. When we check, you might have some indication of inflammatory markers. So what are the risk factors? There are different ones, but basically, if the patient coming to the hospital with what we call not necessarily dementia, but early stage mild cognitive impairment, for instance. And then on top of that, there is UTI, then their chance of getting delirium is higher, if that makes sense. If the same population get dehydrated and on top of that get infections with pneumonia, hypoxia, then delirium might also show up. Other factors or predisposing factors, advanced age as we get older, dementia. If we have any functional impairment, we put this group at higher risk. If you have more than one condition, as earlier mentioned, like renal problem, liver problem, and on top of that, the patient is drinking alcohol. It's common in male, maybe. And if there is any other problems like vision, if they use eyeglasses or hearing aids, then the risk might be higher. We went over some of these. So we want to know when you take a history, you want to identify if there is infection, for example, or if there is anemia. So you want to check the lab. If it's a drug or drug withdrawal. Sometimes it's just simple things like fecal infection, electrolyte imbalance, and so on. The difference between delirium and dementia. Delirium can happen in patients who are diagnosed with dementia at any stage, like early stage, mid, or end stage, but it's associated with the dementia. It can also accelerate cognitive decline. So if the patient is at risk for dementia, and then you put that patient on a risk for delirium, they develop delirium, then that can accelerate the process of the cognitive decline or the trajectory. Like if it's very, very, very slow, what I call an insult. If there is an insult to the brain, then that trajectory, instead of going slowly, they will dive fast or accelerated. Some studies were done, and here are some like people who having fracture, for example, having high delirium risk, cardiac surgery as well, compared to non-cardiac surgery. So, excuse me. When they want to take a patient to surgery, they want to assess them for the possibility of delirium post-operatively. Because the last thing you want to have is a patient, you did a very good surgery, and then the patient get out, go to the floor, get confused, and fall out of bed or while walking and break another bone. So all you did is just waste it, basically, if you don't want to prevent something from happening, such as delirium and the risk of getting confused and falls, if that makes sense. And how do we do that? We just monitor and make sure pain is controlled, anemia is controlled, if they need blood transfusion, if they need iron, make sure the medications that you are giving, make sure they are well tolerated and monitored closely, because sometimes the pain itself can cause delirium. Pain medications can cause delirium. So it's a fine balance where you want to control the pain, but you don't want to overdo it, if that makes sense. Again, it's better to be on one step ahead I did my fellowship in Grand Rapids. It's one city in Michigan, and their hospital they had a floor for older patients. So when they admitted a patient 70 years old or more or older, they take them to that floor, and the staff there they know how to identify, assess, and manage delirium, and also a patient who goes to surgery, they take them after surgery to this floor, or at least they have a floor for post-operative, like orthopedic surgery place where they train the staff or older patients for possible post-operative delirium and so on. So how to evaluate? As in any condition, you want to take a very good focused history, and uh, including review of medication is very important, especially in older patients. So what I do when I round with my students or residents or fellows, I tell them the first thing cause any problem in my population or my patient, you remember it's medication. So the last thing you want to do is you want to be the cause for giving problem to your patient. So make sure the benefit of your medications outweigh the risk. So when you are assessing for this condition, you want to review the medication and see which can cause this, including over-the-counter, as mentioned, alcohol, drugs, and so on. The examination will include all these. What labs you want to check, as we mentioned, anemia, for example, electrolytes imbalance, renal function, you want to check that. And depending on what you found in the history, you may check for urine, liver enzymes, chest x-rays, ECG, EEG, CSF, and so on. So it depends actually on what you find in your history and physical exam, and what that leads you to. Basically, you want to figure the cause, and if it's reversible, you want to make sure you can manage that. Sometimes this treatment may require interdisciplinary effort, like not only the physician can assess the patient, but because the nursing staff will be with the patient for a long time, they may have spent 8 hours during their shift, 12 hours, and they know exactly what's happening with the patient. As a physician, you round and you come to see the patient, excuse me, and it might be only 5 minutes, 10 minutes with the patient. And during that window, you may say, oh, this patient looks fine. He's answering all my questions. How do you say it's delirium? But when you talk to the staff, they say, oh, early in the morning they did this, or at night they do this, and so on. So you want to also get them involved, the family as well, get familiar face for the patient, and so on. If there are factors or contributing issues to the condition, then see if it's reversible. As mentioned, medication, so you stop the medication. Pain, then you address the pain and control that. If they have electrolyte imbalance, you want to replace and monitor the hydration status and so on. Most of the things you want to address in the hospital, the same way in other places, like in a nursing home, you will also assess the same way, manage the same way, basically. You want to restore the function. You want them to be able to basically go back to their baseline, and hopefully you can discharge them in a safe way. They can go back to their home, or if they are from the hospital, you want to transfer to nursing home for rehab and so on, then you want to make sure this is done in a safer way. And you can mention that in your plan when you are writing your start plans. So you can mention the patient had delirium, we did this, and we are planning to do whatever next step. So when the patient is transferred, then the other team, for example, in the nursing home or rehab centers, they can follow through. They can follow if they want to make sure the labs are done, the anemia or hemoglobin is monitored, and so on. We want to get them involved. Basically, this is a list of medication you want to look at that might also cause some of the risk for delirium. We mentioned alcohol, but any anti-convulsant, anticholinergic, Parkinson disease medication, and so on. So when you review the medication, you want to make sure, does the patient really need these medications, because they come with a high risk of causing problem like delirium, or some of them can cause also risk of falls and so on. Try to use a non-pharmacological approach, like if they are disoriented, you want to orient them with putting a calendar or a clock, radio. You want to socialize. Sometimes we have one-to-one sitter at the hospital where a person will sit with that patient for several hours, so that they can reorient them and tell them that you are here for whatever management, and you're gonna go home soon, your family will come soon, and so on. If they are using eyeglasses, you want to make sure they have their eyeglasses available, hearing aids as well. You want to mobilize them. You want to ask a therapy team in the hospital to take them in a walk and so on. It's important to make sure they are hydrated and they are able to eat, feed themselves, and if they need help, then you want to get the help feeding them. And education, especially the family members, to educate them about the condition, because they get confused as well or worry when they see their loved ones in a genetic condition. Like they know them, they're very good, happy, communicating well, and all of a sudden now they are talking about jumping or about driving their car when they don't drive, or doing this and that. So you just want to educate the patient about the condition, the family of that patient about the condition and what to expect and how they can get involved, if that makes sense. We talked about the sitter or family member to help. The goal is to avoid any physical or medication used to restrain the patient. Sometimes you may need to use this Haldol, for example, or injections or physical restraint if the patient is at high risk for harming themselves or harming some of the staff member. Let's say they are punching or biting, then this is not a good thing for the staff or the patient themselves, if that makes sense. Just make sure in every patient you want to weigh the risk and the benefit. For example, if you want to give Haldor, you want to make sure you are following with some measurement like EKG to monitor for QT prolongation. So the last thing you want to do is you want to fix a problem, but you end up with a larger problem, if that makes sense. There are other ways of prevention that the staff can be educated and trained to make sure the patients at risk for delirium are treated before it happens. So there is a help intervention, there is a focus on non-pharmacological approach. So sleep protocol. So make sure if it's nighttime, the light is dim and there are no noises out of the room, so they can sleep during the night and so on. We talked about transition of care. When you want to transfer a patient from one setting to another, you want to get the other team also involved, for example, in a facility like rehab and nursing home. The different guidelines for delirium, the causes and how to prevent and how to manage, but basically try to avoid anything that can contribute to delirium from the start, if that makes sense. So in summary, it's a common condition associated mostly with older patients, mostly in the hospital setting, mostly in surgical floor, but it could happen because of many conditions. Some of you mentioned some of them. There is a CAM, it's a tool, and it comes with different types or different format that you can use in different settings. And the best option is to take a good history exam and, if possible, to try to manage or prevent from happening. If it happens, then manage the condition well. I'm going to stop here and tell me more if you have any patients who you had who may present with similar change in mental status, acute, and what's your perspective? Thank you. Anyone wants to share their experience? Not, is Dr. Malaz or Alaa here?
Hello,
Thank
Dr.
you,
Nader.
Dr.
Yes, I am here.
Nader.
Okay. I will start to share my screen. Is my screen is clear?
Yes. Thank you,
Okay.
Dr. Nader, for the great presentation. Go ahead, please, Dr. Alaa.
Thank you so much. So today I will gonna talk about the new oral Wegovy 25 milligram daily, a landmark advancement in chronic weight management. So this presentation provides a clinically rigorous but IMG-friendly review of newly approved oral Wegovy 25 milligram formulation for obesity. We will cover FDA approval, comparative data, mechanism, and practical prescribing consideration relevant to internal medicine practice and US sport standard. So obesity involves hypothalamic dysregulation, leptin resistance, and chronic inflammation. This is why lifestyle alone results only in 3 to 5% sustained weight loss. GLP-1 agent target the central pathway driving appetite and satiety. That is why it's they formulate this new drug, which is Wegovy for weight loss. So the mechanism of action for GLP-1 receptor agonist, it will gonna enhance glucose-dependent insulin secretion, suppress glucagon, delays gastric emptying, central action on hypothalamic appetite centers, will gonna reduce reward-driven eating, and will gonna improve cardiometabolic markers. These mechanisms explain both metabolic benefit and GI effect. Board love to test the glucose-dependent nature of GLP-1 agonist, the low risk of hypoglycemia, and less combined with sulfonylureas insulin. So both Wagovy and the injected Wagovy both contain semaglutide but differ in bioavailability. Oral semaglutide is co-formulated with the SNAK absorption enhancer. This is important. The patient must take it fasting with a small amount of water. So Wagovy and Ozempic, this is heavily tested. Ozempic equal diabetes, Wagovy for obesity. Even though patient lose weight on Ozempic, insurance rejected for obesity without diabetes. So now regarding the oral Wagovy replaces same molecules, different clinical purpose. Ribelsis does not reach weight loss at the therapeutic level. So efficacy data from a clinical trial. Average weight loss 10 to 15% with oral Wagovy, comparable to some injectable GLP-1 agonists. Subgroup benefit pre-diabetes, PCOS, metabolic syndrome, improvement independent of diabetes. We're gonna do blood pressure reduction, low CRP, better lipid profile. So these results change the landscape and oral option approaching the efficacy of injectable dramatically expand patient acceptance. So the safety profile. Now the most common side effect is GI side effect. And nausea, diarrhea, vomiting, early and gallbladder diseases, pancreatitis. This is one of the serious but rare side effects. So dose escalation is critical to tolerate it. If patients stop too early, it is usually due to rapid titration or improper timing with meals. So now the contraindication. Personal or family history of medullary thyroid carcinoma, pregnancy, severe GI condition. So the drug interaction so we must take it on empty stomach with 4 oz of water. Wait 30 minutes before eating or taking other medication. May affect absorption of thyroid medication, oral contraceptive, and antibiotic. Most exam questions focus on incorrect administration. So now the comparison between Wagovy and other oral agent. GLP-1 agent dominate all oral competitors. Phenterine topiramate is useful but limited by cardiovascular risk. So now the insurance and practical use in USA. So this is often to understand the most frustration of aspect obesity treatment, not the pharmacology. So now the insurance coverage depend on the coverage pattern, prior authorization, and documentation tips. So the key text now, oral Wagovy 25 milligram is major innovation in obesity care. The high dose semaglutide offer near injectable efficacy. So the clear distinction between Ozempic is essential. So we must reinforce that this medication will significantly shift treatment acceptance, particularly among patients refusing injection. Thank you.
Thank you, Dr. Alaa. If anyone has a question or insight, please feel free to open your mic.
Thank you so much, Dr. Alaa. Great presentation.
Most welcome, Dr. Nader. Thank you for the opportunity.
Yeah.
We have also Dr. Malaz, but she experienced some technical issue. Dr. Malaz?
Hello, can you hear me well?
Yeah, we can hear you now.
Okay. Let me share my screen first.
Okay, go ahead, please.
Is it clear, Dr. Sana?
Yes, we can see the beautiful picture.
Okay, hello everyone. I'm Dr. Malaz. And before I begin, I want to sincerely thank Dr. Nadir for this opportunity and for always encouraging conversation that challenge how we practice medicine, not just how we learn it. And we know these conversations truly matter. As clinicians, we renew prescriptions every single day, sometimes automatically, sometimes without fully realizing how much responsibility is attached to that moment, and that means something important. Prescribing is not just writing a medication name, it's clinical judgment, and it's accountability, and it's trust. And we know that over time, routine can make responsibility feel familiar, even when the risk is still very real. So today, I want to ask you a simple but important question. Is prescribing truly routine, or how we simply become comfortable with the responsibility? In Utah, the healthcare system is currently testing a bold and unprecedented idea. They are allowing artificial intelligence, not a physician, to renew certain medication for a patient with chronic condition, not in theory, not in simulation, and not in a research paper, but in real clinical practice. And this forces us to confront something we rarely say out loud. That means many of the decisions we consider clinical are also structured, repetitive, and protocol-driven. And we know that when systems become standardized, automation eventually follows. The question Utah is asking is not whether AI can replace doctors. So the real question becomes this: can a machine safely carry part of our clinical authority without putting patient safety at risk? And this is exactly why this matters, not technologists, not to policymakers, but to us as clinicians. Why does this matter to us as clinicians? First, prescribing is a core clinical act. When we prescribe a medication or when we renew, we are not doing paperwork. We are making a clinical decision. That decision means we are judging whether the benefit is still outweighs the risk and whether continuing this treatment is still safe for the patient. And we know that this responsibility has always belonged to us as clinicians. Second, automation is entering clinical judgment. According to the political report titled Artificial Intelligence Begins Prescribing Medications in Utah, artificial intelligence is not just assisting clinicians in the background. In Utah, a healthcare pilot program is actively testing this idea. The system reviews patient information, asked structured clinical questions, and decided whether a prescription should be renewed, and only when uncertainty is detected does the system escalate the case to a human physician. That means part of what we traditionally consider clinical judgment is now being delegated to an algorithm. Third, patient safety and liability are at stake. As reported in artificial intelligence being prescribing medication in Utah, if an AI system renews a prescription and harm occurs, accountability becomes unavoidable. Who is responsible? The clinician, the company, or the healthcare system that approved this pilot? The report explains that the company assumes physician-level liability and carries malpractice insurance, but we know that responsibility in real clinical practice often feels heavier than what is written in policy documents. And finally, this directly affects clinical practice. What Utah is testing today, as prescribed in Politicus report, may influence how prescribing authority is shared, how supervision is structured, and how responsibility is defined in the future, especially in healthcare systems facing physician shortage and increasing pressure to automate care. So this is not about whether AI is impressive. It's about how far medicine is willing to delegate one of its most fundamental responsibilities. So what is happening? There is a very specific and intentionally designed. First, AI renews prescription. The system does not diagnose new condition, and it does not start new medication. It's only renews existing prescriptions for patients who already have a confirmed diagnosis and an established treatment plan. That means this is continuation of care, not initiation of care, and that distinction is critical. Second, physician involvement is conditional, not routine. A doctor is not reviewing every single renewal automatically. However, physician approval is required whenever the system detects uncertainty or risk. In those cases, the AI escalates the decision to a human clinician. So this is not physician removal, it is targeted physician involvement focused on higher risk decisions. Third, this is a state-approved pilot. Utah has officially authorized this program in partnership with health technology company, Doctoronic. That means this is not an informal experiment or a consumer app. It's being tested within a regulatory framework, with the state actively monitoring safety, accountability, and outcomes. And finally, the scope is intentionally narrow. The program is limited to chronic conditions only. According to Politico report, high-risk medications such as injectables and ADHD drugs are excluded. The focus is on stable patients and commonly prescribed medications, where continuity of access is essential and interruption can cause harm. So when we connect all 4 points together, what Utah is running is a controlled, state-approved pilot where AI renews selected chronic condition prescription with physician approval triggered only when uncertainty is detected. And that model, whether we agree with it or not, represents a real and meaningful shift in how prescribing authority is structured. So the next legal questions becomes, who is actually behind this program? What's important here is that this is not just an AI tool operating on its own. First, the program is developed by a health tech company. Doctoronic, this is not a generic technology startup. According to report, Doctoronic is a healthcare-focused company that designed this system specifically for clinical use, not for consumer self-care. That means the technology was built to operate inside healthcare workflows, not outside them. Second, and this is critical, Doctoronic did not act independently. The company partnered directly with the state of Utah. This tells us something very important. The state was not just aware of the program. The state actively authorized it. That means this is not a private experiment and not a workaround of regulation. It's a government-approved collaboration where the state is allowing innovation while closely observing safety, outcomes, and accountability. And this brings us to the third point. The system itself is an AI prescription platform. This platform is designed to do one specific clinical task, prescription renewal. It reviews patient data, asks structured clinical questions, applies predefined safety thresholds, and only escalates to a physician when uncertainty is detected. So when we connect all 3 points together, what we see is not AI replacing doctors. What we see is a state-approved, clinically scoped system built by healthcare technology company operating under regulatory oversight and intentionally limited to another clinical function. And that distinction matters because it tells us this program is testing governance, responsibility, and trust just as much as it's testing technology. The next clinical critical questions become, why was this pilot created in the first place? The purpose of this pilot is not to prove the AI is powerful. It's to answer very specific clinical and regulatory questions. First, this pilot is designed to test the safety of AI prescribing, and here safety does not mean speed or convenience. It means asking a very clinical question. Can an AI system safely handle prescription renewals without increasing patient harm? According to political reports, this is why the scope is narrow, why physician approval is triggered when uncertainty appears, and why high-risk medications are excluded. So safety comes before scale. Second, the pilot aims to measure patient and policymaker trust. This is not only a technical experiment, it is a social and professional one. The state is observing whether patients are willing to accept AI involvement in prescribing and whether policymakers are comfortable allowing this level of automation. In one of medicine's most sensitive acts, because we know that no clinical innovation survives without trust from patients, clinicians, and regulators. Third, the pilot evaluates the scalability of automation. In other words, can this model operate reliably beyond a small group of patients? Can it reduce medication lapse, support overstretched systems, and function consistently as volume increases without compromising clinical judgment? That is questions every healthcare system facing workforce shortage is asking right now. And finally, the pilot is designed to generate regulatory evidence. This is critical. The data generated from this program will help regulators decide how AI prescribing should be governed in the future, whether at the state level or potentially at the federal level. So this pilot is not just testing technology, it is producing evidence to shape policy regulation and oversight. In short, this pilot exists to answer one central question. Can AI be integrated into prescribing in a way that is safe, trusted, scalable, and governable? Now, let's understand how the system actually works from the patient perspective. At the end of the day, this is a digital platform that patient actively uses, not an invisible algorithm running in the background. The process starts when the patient enters the platform and requests a prescription renewal. The patient logs in, identifies themselves, and submit a request to renew an existing medication. Only after the patient initiates the request does the system begins its workflow. One of the first things the system does, it verifies the patient's physical location. The platform confirms that the patient is physically present in Utah. This step is critical because prescribing authority is regulated at the state level. If patient is not in Utah, the system does not proceed. So before any clinical decision is made, the platform enforces legal and regulatory boundaries. Once location is confirmed, the platform then retrieves the patient's prescription history. This includes the medication name, dose, refill timing, and whether the prescription is eligible for renewal under the pilot rules. It also confirms that the medication is linked to a chronic condition and falls within the approved medication list. At this stage, the system has clinical context, very similar to what we review when we open a patient's chart. Only after this context is established does the system move to AI-led clinical questioning. The patient is asked a series of structured questions about symptoms, side effects, adherence, and any change since the last prescription. These questions are designed to detect red flags, the same thing that would make us pause as clinicians. If the answers remain within safe parameters, the system can proceed. If any response raises uncertainty, the case is escalated for physician review and approval. So the system does not replace clinical judgment. It filters cases and directs high-risk situation to a doctor. Once the renewal is approved, either automatically or after physician review, the final step takes place. The prescription is automatically transmitted to the pharmacy. This reduces delays, prevents interruptions in chronic therapy, and supports continuity of care for the patient. So when we look at the full workflow, we are not looking at a single AI decision. We are looking to a platform-based process where the patient initiates care, clinical history is reviewed, safety is actively screened, physicians are involved when risk appears, and only then in the prescriptions renewed. That is how the system workflows in practice. So the next critical question becomes, how far does the system go? And just as importantly, where does it stop? What we are seeing here is the scope of prescribing, and this scope is intentionally narrow by design. First, the system is limited to around 190 medications. These are commonly prescribed drugs primarily used in chronic disease management, medications with well-established dosing, safety profile, and monitoring patterns. That means the platform is not experimenting with complex or unfamiliar therapies. It's operating within a carefully selected medication list where renewal decisions are relatively standardized. Second, the system handles routine renewals only. This is a crucial distinction. The AI does not initiate treatment, it does not change doses, and it does not introduce new medication. It only reviews prescription, where the treatment plan has already been established by a clinician. So, the clinical decision to start therapy remains human. The platform only supports continuity of care. Third, the focus is on chronic disease management. These are patients who rely on consistent access to long-term medication for conditions like hypertension, diabetes, and hyperlipidemia. In these cases, as we know, the biggest clinical risk is often not overtreatment, but interruption, missed refills, delayed renewals, and medication gaps. By targeting chronic conditions, the system is designed to reduce those interruptions without altering the underlying clinical strategy. And finally, high-risk medications are explicitly excluded. According to Politico report, this includes injectables, controlled substances, and medications that require closing titration and intensive monitoring. This exclusion is deliberate, and the overall design is restrained. It shows that the system is designed to recognize it where automation is appropriate and where is not. So when we connect all 4 points together, what we see is a prescribing model that is limited, conservative, and deliberately restrained. It's not trying to replace clinical judgment. It's trying to support safe, routine, continuity of care in a very specific clinical space. And that narrow scope is exactly what makes this pile possible. Now we reach the most important question of all. How does the system stay safe? What you are seeing here is not a single safety feature, but a layered safety architecture built into the platform from the start. The first layer is conservative decision threshold is specifically designed for UDA. The system does not operate at the edge of uncertainty. Its thresholds are intentionally conservative, meaning the AI only proceeds when clinical signals are clearly within safe limits. Any borderline case is treated as unsafe by default. So the system is designed to fail safely, not to push decision forward. The second layer is automatic escalation. When uncertainty appears, if at any point the data is incomplete or inconsistent, or the patient's answers raise concern, the system does not attempt to resolve that uncertainty on its own. And instead, the case is immediately escalated for physician review. This is a critical design choice. Uncertainty does not trigger autonomy. It triggers human involvement. So, clinical judgment is not replaced. It's activated precisely when it matters most. The third layer involves physician oversight of initial prescription. The AI does not initiate treatment. Initiate prescriptions are written and reviewed by physicians. The system only operates downstream, supporting renewal decisions once a treatment plan has already been clinically established. That preserves the core medical act of diagnosis and initiation as a human responsibility. The final layer is explicit exclusion of high-risk drugs. Medications that require close titration, intensive monitoring, or carry higher risk profile are explicitly excluded from the system. This includes injectables, controlled substances, and drugs where even small changes can have significant consequences. This exclusion is not a weakness. It is a safety signal. When we connect all these layers together, what we see is a system that is not designed to replace clinicians, but to operate around them safely. Conservative threshold decide when AI can act. Automatic escalation decides when humans must step in. Physicians retain control over initiation, and high-risk domains are kept entirely out of scope. This is what makes appellate credible from a clinical safety perspective. Because the real question is not whether AI can prescribe, but whether it knows when not to. So, this brings us to the performance data. And this is where the discussions became evidence-based, not hypothetical. According to the data shared with you, regulators, Doctronics AI systems were compared directly with human clinician across 500 urgent care cases. These were real clinical scenarios, not simulation, not synthetic data, but real prescription renewal decision. The key outcome measured here was agreement with physicians. In other words, how often did the AI's decision match what a physician independently decided in the same case? The reported agreement rate was 99.2%. The number is striking, but it needs to be interpreted carefully. This does not mean the AI has clinical superiority over doctors, and it does not justify unleashing AI into restricted clinical decision making. What it means is that within a narrow controlled scope, the AI's renewal decision aligned with physician decision. In the vast majority of cases, this level of agreement suggests that for routine prescription renewals, automated system can perform reliably when strong safety guardrails and in place, and those guardrails matter because they define where automation is acceptable and where it must stop. However, and this is crucial, this data does not eliminate risk. Instead, it helps regulators and clinicians understand how to use AI deliberately, not impulsively. This is exactly why the pilot is structured the way it's. High agreement is controlled setting supports limited deployment, but uncertainty is still triggers escalation to physicians, and high risk decisions remain outside the system entirely. So when we connect this data to everything we have discussed so far, what we see is not a claim of a superiority, but a justification for a caution. The performance data support testing AI in prescribing, not unleashing it. The question is not where AI can match clinician in narrow tasks. This data suggests that something it can. The real question is whether we are using that capability safely, deliberately, and when clearly defined guardrails. Now let's ask a very practical question. What does this actually mean for patients and for healthcare system? This brings us to cost and access. One of the main goals of this pilot is to make prescription renewals more affordable and more accessible, especially for patients with chronic conditions. The system currently charges about $4 per renewal. This is significantly lower than the cost of traditional clinic visits just to renew a stable medication, and this cost is intended to decrease with scale, meaning the more the system is used, the cheaper it becomes. For many patients, renewing a prescription currently means booking an appointment, taking time off work, and paying consultation fees. This model removes that burden when a full clinical visit is not medically necessary. Improve access for chronic patients. This is especially important for patients with chronic diseases who need routine renewals, not repeated reassessments. Improving access here does not mean cutting corners. It means removing frictions from safe, stable care pathways. Reduce medication gaps. Another key benefit is reducing medication gaps. Missed renewals can lead to uncontrolled blood pressure, poor glycemic control, and preventable complications. By making renewals cheaper and easier, the system helps patients stay adherent to long-term treatment. So when we connect cost and access together, that what we see is not just a tech solution, but a system-level attempt to reduce barriers without compromising safety. This pilot is testing whether AI can make routine care more affordable, more accessible, and more continuous while keeping clinicians firmly in the loop. Now comes the policy question. Why would a state actually support something like this? This is why IOTA supports this pilot. Rising healthcare costs. As we know, healthcare costs in the US are rising year after year, and states like Utah are actively looking for ways to contain costs without reducing quality of care. Automating low-risk routine tasks like prescribing renewals is seen as one way to exactly that provider shortage. Utah, like many states, is facing real provider shortage, especially in primary care. That means fewer clinicians managing growing patient volumes. This pilot allows clinicians to focus on complex clinical decisions while routine renewals are handled safely in the background. Rural access challenges. Large parts of Utah are rural. For many patients, accessing care means long travel times. Just to renew a staple medications, AI-supported renewal help reduce that barrier by bringing care closer to that patient, not forcing the patient to travel to care. Reduced clinician workload. Clinician burnout is a growing concern by reducing administrative workload, not clinical responsibility. Systems like this aim to support clinicians, not replacing them. The goal here is refill, not removal. So when Utah looks at this pilot, it does not see just an AI experiment. It seems a potential response to cost pressure, workforce shortage, and access gaps, all while keeping physicians in control. Utah supports this pilot not because AI is existing, but because the healthcare challenges it faces are very real. And that brings us to a critical question. What are physicians actually concerned about? These concerns are real, valid, and deeply rooted in every clinical practice. Loss of nuanced clinical judgment. Prescribing is not a checklist activity. It is deeply contextual. Clinician does not evaluate lab values or medical names. They read between the lines. Changes in symptoms, patient behavior, social circumstances, and clinical intuition built over years. A major concern is that automation may miss this nuance. Clinical judgment is a subtle reasoning that cannot always be captured by structured data. Risk of misuse or abuse. Another concern is risk of misuse or abuse. Physicians worry that patients may learn how to answer system questions strategically to obtain renewals inappropriately. This concern is especially serious in the context of medications with dependency or harm potential, which is why this pilot explicitly excludes high-risk drugs and applies strict eligibility rules. Clinicians are trained to constantly think about interaction, not just the drug-drug interactions, but also drug-disease and drug context interactions. Physicians worry that an automated system may miss less obvious interactions, especially when patients receive care from multiple providers or use over-the-counter medication inconsistently. This is one of the strongest reasons for automatic escalation to a physician when uncertainty appears. Finally, there is a concern about whether AI can truly assess context. Contextual assessment includes factors like recent hospitalizations, adherence patterns, social instability, or clinical changes that may not yet be documented. Physicians worry that without a full understanding of the patient's life reality, even a technology correct prescription renewal could be clinically inappropriate. When we put all these concerns together, one message became very clear. Prescribing is not just about data, it's about judgment. And that's exactly why this pilot was never designed to remove clinician from the loop, but to define where automation can assist without replacing clinical responsibility. And we know physicians are not rejecting innovation, they are protecting the depth and safety of clinical care. And the success of this pilot depends on how seriously these concerns are addressed. Once these concerns are on the table, the conversation naturally moves to one big question. If AI is involved in prescribing, who carries responsibility? This pilot makes one thing very clear. AI is not operating alone. A responsibility is not pushed onto doctors unfairly. AI systems covered by malpractice insurance. The AI system is covered by malpractice insurance. This means the system is treated like a real clinical tool, not an experiment, not something informal. So risk is acknowledged, planned for, and insured. Physician level accountability still applies, even with AI involved. The standard of care stays the same. Care is still judged by medical standards, clinical safety, patient protection. And AI not lower expectations and does not change what safe care means. Legal liability remains with the company. And this point is very important for doctors. If harm happens because of system design, algorithm failure, automation error, the company carries the legal responsibility, not the individual physician. So doctors are not replaced and they are not left unprotected. The next question is, how does the medical community respond to this? And this is where the American Medical Association comes in. The AMA does not reject AI and does not blindly accept it. Its position is balanced and practical, supports innovation in healthcare. The AMA recognizes that healthcare systems are under pressure, doctors are overloaded, access gaps are real. So yes, the AMA supports innovation when it improves care and reduces burden. Warns against AI without oversight. At the same time, the AMA is very clear. AI must not work without oversight. They warn against unsupervised AI, automation without clinical checks, systems that bypass doctors completely. The concern is not AI itself, the concern is AI without control. Emphasizes physician involvement. This is the AMA's strongest message. Physicians must remain involved. AI should assist doctors, support decisions, reduce routine work, but final responsibility and judgment must stay human. And this is exactly why the Utah pilot looks the way it does, AI assisted by physician involved. Now we arrived at one of the most complex and sensitive questions in the entire discussions, how this is actually regulated. And this is where uncertainty begins. Is this practicing medicine? The first regulatory question is very fundamental. We have to ask, is an AI system that renews prescriptions actually practicing medicine? Because practicing medicine traditionally means clinical judgment, decision-making, and responsibility rules that have been historically reserved for licensed physicians. So when an AI system renews a prescription, the concerns become very real. Is this still a medical act, or has it crossed into automation, clinical decision making? If AI is considered to be practicing medicine, then logically it should fall under medical licensing laws, just like any human clinician, or it's regulated medical technology. On the other hand, the system could be viewed as medical technology. In this model, AI is not replacing physicians. It is assisting care, operating within predefined rules, safety thresholds, and guardrails. Here, the AI functions more like a clinical decision support tool rather than an independent prescriber. If classified this way, regulation may fall under technology or device oversight instead of physician license framework. And this distinction is absolutely critical because it determines who regulates, how regulations happens, and who holds responsibility when something goes wrong. Authority remains unclear. And this leads us to a core issue. Regulatory authority remains unclear. It is still not fully settled whether oversight belongs to state medical boards, state health departments, or federal agencies. This regulatory uncertainty creates a gray zone where innovation is moving faster than regulation can realistically adapt. So this pilot is not only testing clinical safety, it is also testing regulatory boundaries. It's asking a much bigger questions. Where does medicine end and where does technology begin? And this uncertainty is not accidental. It reflects how new this tertiary truth is. And this pilot is helping regulators learn how to govern AI in medicine before the technology scales nationally. But uncertainty does not stop there, because once we ask how AI should regulate it, the next unavoidable question becomes who actually has the authority to regulate it? And this is where the real tensions begin. First, the state perspective. Traditionally, states regulate medical practice. They license physicians, define scopes of practice, and oversee how care is delivered on the ground. So from a state perspective, prescribing medications, even renewals, has always been viewed as a clinical act. And naturally, when AI becomes involved in prescribing, states see this as falling squarely within this responsibility. But there is where the shift happens because AI does not fit into the traditional definition of a clinician. It does not hold a license, it does not belong to a medical board, and it does not practice in a physical clinic, which leads us directly to federal side of question. Now, the federal perspective. At the federal level, the FDA regulates medical devices. If AI is framed not a clinician, but a medical technology, then federal oversight becomes relevant. In this framing, the focus is not on clinical judgment, but on safety, performance, and risk management. And this is where problems emerge because AI prescribing does not sit fully on either side. Prescribing looks like medical practice, which points towards state authority, but AI functions like a technological system, which points towards federal oversight. In other words, AI prescribing blurs the boundary between state-regulated medicine and federal regulated technology. So this pilot exists in a regulatory gray zone, right at the intersection of state medical authority and federal technology regulation, and that tension is not a flaw, it's exactly what this pilot is exposing. And this is not just about Toyota, and it's not about AI, it's about how modern healthcare systems decide who governs clinical decision making when technology becomes part of care team, and how this question is answered here may shape AI regulation far beyond one state. So now, move forward. What happens if this works? What happens beyond IOTA? This slide is about expansion yet. It's about preparing the ground. Right now, IOTA is not acting in isolation. Other states are watching closely, asking questions and starting discussions. They want to understand safety outcomes, physician involvement, and regulatory lessons. IOTA is effectively becoming a reference model, not a finished template, considering a national approval pathway. At the same time, there is early thinking about a national pathway, not automatic rollout, not fast scaling, but a structured question. If this expands, what is the correct national route? This is signals, cautions, not speed. Depending on FDA response, and this is the key constraint. Any expansion depends on the FDA. The FDA's response will determine classification, oversight requirements, and limits of use. So growth is not driven by hype, it's driven by regulatory permission. This tells us something important. This pilot is not designed to spread fast, it's designed to spread correctly. Evidence first, rules next, expansion last. So Utah is not just testing AI prescribing, it's testing how innovation should responsibly grow in healthcare. Finally, let's step back and look at what this really tells us. First, AI is no longer theoretical in healthcare. In Utah, it is already touching one of the most sensitive clinical acts, prescribing. Second, this is not about replacing doctors. Utah is testing a clinical boundary where automation can help and where human judgment must remain central. Third, the benefits are real. Better access, lower cost, fewer delays, but they coexist with serious risks, clinical, ethical, and legal. And finally, technology is not hardest part. Oversight is rules, accountability, and physician involvement matter more than the algorithm itself. So this story is not really about AI, it's about how medicine chooses to evolve. Utah did not ask, can AI prescribe? It asked a far more important question. Can AI be integrated into medicine safely, responsibly, and under human control? This pilot shows us one thing very clearly. The future of healthcare will not be decided by technology alone, but by the values, safeguards, and clinical judgment we choose to protect. If we get that balance right, AI becomes a tool that strengthens medicine. If we get it wrong, no amount of innovation will save us. So the real question is not whether AI belongs in healthcare. The real question is how widely we allow it in. Thank you so much. I'm happy to take your questions.
Thank you so much, Dr. Malaz, for this great presentation for interesting topic. Dr. Nadir, do you have any insight or comment?
Thank you so much, Dr. Malaz, for great presentation. Thanks. This is great and wonderful. Thank you. Any other
Thank you,
comments?
Dr.
Yes, I do have a comment.
Yes, go ahead, Dr. Lorraine.
So this topic is very interesting because an American doctor, like 2 years back, has spoken about how this affects like IMG, which is very interesting that we see it in Utah right now. He said that AI replacing the need for IMG is not a question of if, but rather when, as to how like it's simply more cost effective. And what's really stopping it is just the development of AI in general, right? Like Dr. Malaz just a while ago talked about how there are disadvantages, but which can, be patched or which can be fixed like in later on, like how ChatGPT is improving. He said 2 years back that it's not only because it's legally and the ethical proportion of it, right? So he said that lawmakers in the foreseeable future will start talking about the lack of doctors or just in general like overload and or like what do you call it? Burnout in physicians in general or blah blah blah, etc. Right? And so later on they will pass a law talking about like the regulation or like slowly implementing AI into states that are underfunded or like are underrepresented, right? And which like they slowly put out the AI technology in which you know in which it's with its integration, this will cause in general the healthcare of America to need IMGs less. But while it's like rather an interesting thing to like to think about or like it's an interesting thing that he brought out. And as I said, like now in Utah it is actually like it's I don't know if it's actually going to replace or yes, it's going to be a tool. It's interesting because like so far all of our discussions about like AI and technology has been very optimistic or like how it will integrate into the future, but like which was rather interesting because like American doctors over there are suggesting maybe a dystopian look into the future. So I would like to ask the people, like, what do they think about it? Like, what do they see of, like, or in general, like as an IMG in general, like, what do you guys think?
Excellent points. The floor is open if you wanna add anything. Guys, share your input. Any comments from you guys?
Hi, hello everyone. Am I coming through okay?
Yes.
Okay, I just want to add that I don't think AI gonna replace doctors anytime soon, like totally replace them. It's just gonna be a tool to aid them more. But the AI lacks the human emotional touch that many patients really seek, the grounding effect of being with another human that listens to you and appreciate your pain and suffering. AI is just so mechanical for that, giving those AI generated replies, and I don't know that what patients are really there to listen to. It's a great tool, yeah, and it's gonna decrease the burnout rate, of course, it will. But to replace a human being with a machine, I don't think that is going to happen anytime soon.
Yes, but he meant it in the way of the need for international medical graduates, right? So we're talking about American graduates. Like there's a good amount of American graduates now, right? So if like there, what he's implying is that there's a lesser need for international medical graduates. So that was his thing, not entirely like AI replacing, but the need for IMG is going to be less.
And why exactly IMGs?
Be,
Like,
because it's their country, right? So if I were to look on like the pool of 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 people, basically, like you have American grads versus like international grads. Of course they favor American grads because at the end of the day that's their country, and it's the privatization. It's the same thing that is in Britain. So he just talked about that in a way. So yeah.
I
I
don't know
have
how to. Okay, thank you. But I don't think that's going to happen. There is a huge shortage of physicians in the USA, whether they are, regardless of where they are coming from. I'm not sure about that, honestly.
I believe AI has helped us a lot in a lot of aspects, and as we are IMGs, really, I found myself very well when I use AI and help me in many things, not only in medicine. I can even when I apply for residency program, really it helped me a lot. It helped me in my work. Also, I work now as behavioral therapist. So I found really AI like support us and give a lot of assistance. So it is very nice thing, and really this is a very supportive for us.
Yes, it is. Yes, of course.
Excellent discussion. Other comments?
My question for Dr. Malaz, regarding the tools she talked now about AI, does that only on med in like a pharmacy or in medicine like chronic diseases? So that means it doesn't like spread in all the other aspect of specialties. It's only depend on like primary care provider like family physician or in the primary care. So we cannot use this part of tool in the other specialty. Am I right or no?
Melas, you are muted. I can answer that and Melas can add more. Oh, go ahead.
Yes, yes, Dr. Renata. As I said during my discussion, this system is involved mainly with chronic conditions. Okay, for even so, any condition which is actually needed, you can say to be with all of, you can say, primary care, or even so like conditions emergency, or even so conditions that urgent critically and need you can say consequences as and to be, you can say, focusing with specific changes and so on. This is not actually involved. Okay, it's just involved in the chronic conditions like as I said, like diabetes, like hypertension, like hyperlipidemia, because already all the history is involved in the platform. Okay, and even so when the patient is entering and opening the platform, after the verified this patient is in Utah, and then all the history will gonna be you can say appear. Okay, and then they will gonna ask the patient, even so if this patient have any side effect, if this patient have any, you can say, new symptoms and so on regarding these medications used, and if they, even so this chronic patient have any symptoms, the platform will not prescribing, you can say, ordering you immediately. They will even so make red flags. Okay, and the doctors or the physicians, you can see, we're gonna see these red flags, and then we're gonna review these red flags, what's in, and then if we're gonna give the approved or not. So this platform is definitely not given to review. This just for renewed for the chronic conditions already. They have they actually not need, even so you can say, clinical decision. As we said, like this platform not cannot make any clinical decision, not replacing doctors, like just for renew, like just as we, you know that like sometimes when you renew the prescription for patient with chronic conditions, the patient not have any new symptoms, right? Just you will gonna renew. This will gonna save the time for the patient, save the cost from booking new appointment, and even so save your time even so from the clinician burden. Okay, but even so there is any other conditions need clinician review and clinician decisions and so on, this is totally out. Okay.
Thank you so much. And I think it's mainly for refills, so it's not for a new medication. So the
No.
patient will be already evaluated and prescribed, and then for the follow-up, they want to refill. So the app or the program or the AI will do that instead of the physician spending the time again review medication and then refill and send the, because it will take some time out of the physician. As Malaz mentioned, they have a follow-up appointment, so you have to spend 15 minutes with the patient. If they don't have any new addition, then you have to click on each medication and then submit it to the pharmacy for refills and so on. So this will save you a few minutes for each patient, which accumulate to something that might save some time for the physician to do other stuff. Thank you so much, Malaz.
I have a comment also for Dr. Nadia. I heard about a new AI program or tool also available here in Washington, and it get approved 2026 this year. It's help to documentation with the documentation. And for us as IMG, this is a huge step because it helps you to organize your thought, write the history in a specific manner and systemically, and also save you a lot of time. So hopefully, yeah, I can talk about it when I have more information in the future.
Thank you so much, Dr. Sana.
Thank you, Dr. Sanat.
So I have a quick question for Malaz. Great presentation. How did you create slides? If you can walk me through the steps. And I'm asking this because for new fellows in this program, they will sometimes feel hesitant of participating, taking the steps to present and so on, specifically when we give them only the title or an article that the same way. Can you just walk me through the steps so that I can show new fellows how it's done? Thank you.
Thank you, Dr. Nader. Thank you so much. Okay, actually, when I selected, you can say the presentation I want, then actually I'm looking for the source, okay, which is actually you attach for us, if it's a post or if you can say it's PDF or even so like an article and so on. And then actually I read it, okay, and then you can say take the more important point, which will let me to be directed during the presentation. And then after that, use even so, try to summarize it, okay? And even so, try to make the bullet points. And then after that, if need, you can say AI to help me to summarize, give him promote for the to summarize, but with all instructions, not let me to be out of my concept. And then after that, I love Canva actually. I used it, okay? I'm trying, I'm doing actually every time brainstorming regarding the concept actually, or you can say the visual and layout I need it to be in my presentation. And then I opened Canva. Canva, it's actually very great for us as doctor because provide for us literally, you can say creative layout and creative visual screens and so on. So and then after that, like for example, if my title is regarding the health, for example, this is AI prescribes medication in Utah. So my concept it will gonna be, for example, I did brainstorming and so on. It's about the doctrine after after I read the presentation. You can see content. Then I visualized in my brain like I need doctor and I need the patient and I need this doctor need to be involved. And I need even so my background to be like containing AI or you can say digital health at the end or something to support this concept. And then I opened layout, like layout for the doctor and doctor with patient on clinics with the, for example, like sitting, okay, in clinically, clinical clinics, which is within the modern health system, okay, or you can say modern health clinic. And then after that, even so in this screen, I tried, for example, looking for the picture, okay, which is actually we're gonna this support doctrine, which is for the medications and so on. And even so took all of this from the Canva, okay? And then attach even so in the screen, okay, in the iPad, in the picture itself. And very important, the background, even so search in background, like all of that, I give it in the AI inside the Canva. I use Canva with all.
Thank you so much for all these steps and explaining how you created your presentation. Thank you.
Thank you so much.
You're welcome. Dr. Fatma, go ahead.
Hello. I want to share my experience with AI when I was doing my gerontology master's. I'm still doing it.
Yes, please.
Excuse me, my voice like is gone because I have cold. Okay. Especially I used AI version called Chatbot. It's paid, but it's not that much. It cost me like less than $50 a month, but it played an important role in supporting me throughout my master's program in gerontology. They helped me, chatbot specifically helped me to understand the complex academic concepts, and it also helped me to summarize the research articles, organize sources efficiently. Also, it was useful in managing references, structuring assignments, and this reduced the stress and improved the quality of my work. Thanks God, Alhamdulillah, I got A+ in all my stuff. So after Allah, Alhamdulillah, it helped me a lot. Especially my English is not my first language. Sometimes I have challenges in some stuffs. Also, it's enhanced my learning experience, strengthening comprehension, organization, and I felt so confident, more confident, and allow me to focus more deeply on the human and ethical aspects of aging. So it was very good experience. So my recommendation is like try to use AI and don't hesitate to use it. Of course, I use it, but I don't have to use it in everything because everyone knows as doctors, like we have to use our minds to refresh it and build our skills. Thank you for giving me this opportunity to talk.
Thank you so much for sharing and congratulations for your A+. Great. Good job.
Thanks, Dr. Thank you. Thanks.
Thank you.
Dr. Nadir, if you allow me, I want to share a little bit about Canva. So if the presenter will know about that.
Yes.
So I will share my screen. So for use Canva, you can go for canva.com and just register your email and sign up. And after that, you can find a video on YouTube. It is 2-minute video. I have it here, but you can watch it and it guide you how to use Canva. It is a very simple and very easy to use. It has everything. You can choose the design from here for your presentation. You can have entertainment if you want to add picture like that, or you want to add any 3-dimension photo or something. If you doesn't like that, you can just remove it, as simple as that. It is very simple to use, and you can add text and upload videos and use other tools, and it has everything like magic media applications, videos, and also AI voice. If you want the presentation to has AI voice, you can choose your voice, what voice you want. And also it has editing tool. So it is very simple and it's a great tool, and you can use AI inside the presentation and in every slide. You can add slide, you can remove a slide, and it is a free version. There is paid version, but the free version allow you to do a lot, and it is very simple if you don't good in the AI stuff and computer stuff. So it is a very great tool.
Thank you so much, Dr. Sana. This is also very informative.
Thank you.
Thank you, everyone. Any updates? Anything going on? Any ideas, questions, comments, projects?
I have an update for the season. I luckily, alhamdulillah, I get just one interview, and I did it already, and it was amazing, and the people was very professional, quiet, and kind. So I want to reassure my colleague, if they have upcoming interview, don't stress out. They are very professional, and they will and you will get this inshallah. I'm waiting the result. I didn't have any other chance for interview, but my hope that may Allah help me to pass this and get match. And even if I didn't get that match, I will still work. And by the way, they asked me a lot about the telegeriatric fellowship research, and they asked me so about the program, how it's work, how it's helped me, and about my role in the program. So please, my colleague, if you have any upcoming interview, get ready to answer this question regarding the telegeriatric fellowship. They will definitely ask you about that. And I hope the season will get we get all chance to interview and get match. And if we didn't, we have to fight and get into SOAP and fellowship and just move toward our goal. And inshallah, one day we will be there, inshallah.
Inshallah. Thank you so much, Dr. Sana, for sharing, and congratulations for the interview. And we wish you and all the rest successful and happy. And we hope all of you match and start your residency or training in the field that you feel fit for you. And it only takes one interview. So I wish you all the best, all of you. Thank you.
Thank you, Dr. Nadir, and all my colleagues.
Thank you once again, and thank you all the presenters. Thank you all who joined this meeting today. Thank you, Dr. Sana, and your team. And I'd like to thank those who will watch the recording in the future. Assalamu alaikum. We'll see you next week. And if you have questions, please let me know. We'll be happy to help you guys. Assalamu alaikum.
Alaikum assalam wa rahmatullah, Dr. Nadir. Thank you.